Hello and welcome to the Dizziness and Balance video series by the Ear and Balance Institute. I am your host, Dr. Jared Gianoli, and I am a board-certified neuro-otologist. Neuro-otology is the medical specialty that deals with inner ear dizziness and balance disorders. This video series is intended to be educational and not intended to be medical advice. For individual medical advice, please speak with your own physician. Well, welcome back. Today we're going to talk about something that you won't usually hear associated as a cause for vertigo and dizziness. It's something that's very much underdiagnosed, and it's also increasing in frequency. That condition is elevated intracranial pressure. Well, it's long been known that elevated intracranial pressure can cause problems, and it's got a lot of different names. It's been called pseudotumor cerebri. And that dates back to it sort of provokes or causes symptoms like someone has a tumor, but they don't have a tumor in their skull. It's also been called idiopathic intracranial hypertension, and it's been called benign intracranial hypertension. And the way this has been diagnosed in the past is the doctors will look in your eye and see swelling behind the eye or where the nerve comes into the back of the eye. It's called papilledema. And say, oh my goodness, it looks like there's swelling in the back of the eye. The patient must have increased intracranial pressure, and that would lead to the diagnosis. Well, what we have found is that there's a lot of folks that have elevated intracranial pressure that causes problems with dizziness and headaches, but it doesn't cause papilledema. In fact, what we have found is that most of the time, patients don't have the swelling behind the eyes. A colleague of mine, Dr. Bulent Mamagoglu, up at New York Medical College in Westchester, and I wrote a paper about this recently describing an entity that we think is underreported, and we call it mildly elevated intracranial pressure. And those are folks that don't have the papilledema and don't have really high pressure, but it's high enough to cause problems with their inner ears, and lowering that pressure makes the patient significantly better. So how does high pressure cause problems? Well, first of all, when the pressure is high inside your head, it will stretch the covering of the brain, what we call the dura, and that causes headaches. And the headaches can be in a variety of different locations. It can feel like it's throughout the entire head or located in just one particular spot. It can also push the spinal fluid down the length of the optic nerve, and that's how it can cause swelling behind the eyes. The spinal fluid also is connected to the inner ear, and hence the pressure getting transmitted to the inner ear can cause a pulsing pressure going to the inner ear that can cause problems with tinnitus, hearing loss, and damage the inner ear, causing vertigo and dizziness. So what are the main symptoms that you should look for in a case you're suspicious of elevated intracranial pressure causing your dizziness problems? And number one would be pulsatile tinnitus. And by that, I mean hearing something that sounds like your heartbeat in your ear. It doesn't necessarily have to be your heartbeat. It's probably not your heartbeat, but the pulsations of the spinal fluid. And the easy way to identify that for yourself is to take your pulse and see if the pulsations in your ear are in time with your heart rate. As I mentioned, the other big symptom is headaches. And this is something that can be confused with migraines, because migraines obviously cause headaches as well. Probably the biggest difference between the headaches you get from increased intracranial pressure and migraines is that the headaches from intracranial pressure elevation is generally there almost all the time. Now, it will wax and wane. Sometimes it's really bad and other times not so bad. It can go away, but it's there more often than it's not. Whereas migraine is an episodic phenomenon that comes and goes, and in between the headaches, they're essentially free of any headaches. Other symptoms you will see are pressure and fullness in the ear. It can actually give the patient a feeling like they're in the bottom of a barrel. Or that they've got something covering their ear. And if you do a hearing test, sometimes you'll actually see some low-frequency hearing loss in these folks. Patients can have pressure in their sinuses or in their eyes. And a number of these folks will think they have sinusitis, and when they go to the doctor saying, "Doctor, I've got a sinus infection," and the doctor will look in there, they don't see any evidence of any infection. They'll even do x-rays or scans and find nothing in the sinuses. And in most of these folks, it's because of the referred sensation of pressure from the increased pressure inside the skull. And then the last big symptom you get is dizziness, which can be rather vague, but you can actually get episodes of spinning vertigo or feeling like you're spinning around, or the environment is spinning around with you. Additionally, some of these folks will get a rocking sensation, and we believe that's due to the pulse waves of the spinal fluid affecting the balance sensors in the inner ear, and that when the pulse comes here, the balance sensors get moved back and forth as if you were on a boat. Well, what causes this increased intracranial pressure? There's a bunch of causes. First thing is to make sure that you're on no medications that will cause this. And if you look at the list of medications that can potentially cause increased intracranial pressure, it is extremely high, including just about every antibiotic everyone's ever taken. But the main ones that you see this with are, one, you can see it with any of the vitamin A derivatives, like they use for acne patients. Two, the main antibiotic that we see that can cause this are the tetracycline antibiotics. And then they're also, believe it or not, steroids have an interesting phenomenon with increased intracranial pressure. When you start steroids acutely, it actually lowers intracranial pressure, but then the longer you're on it, it can actually cause increase in intracranial pressure. So those are some of the medications to be concerned about. There's a number of systemic disorders, including chronic renal insufficiency, anemia, and a whole host of other medical problems. Endocrine disorders are very prominent: hypothyroidism, hypoparathyroidism, low testosterone, etc. So those need to be considered. Obesity is probably one of the biggest factors associated with elevated intracranial pressure. And as we're seeing weight go up across the United States, we're seeing higher incidence of increased intracranial pressure. There's several different possibilities why obesity lends itself to this, and that's being actively investigated. And then another big common problem that you often see that comes along with obesity is something called obstructive sleep apnea. And this is a case where people will fall asleep at night, and their airway in the back of their throat will collapse to where they can't breathe for a period of time. And while that happens, the oxygen level goes down in the blood and the carbon dioxide level goes up. And the only way to fix that problem with the brain is to increase the blood flow to the brain, which increases the pressure. So a number of these folks will have increased pressure, especially at night, but it gets better during the day. Very often with patients with obstructive sleep apnea, they'll talk about having headaches first thing in the morning that get better throughout the day, and that's presumably because of the increased pressure. The last cause I'm going to talk about, and it's not the only causes, but it's a blocked or kinked dural venous sinus. Now, the dural venous sinuses are the two major veins that drain blood from the brain. And if one of them gets blocked, either by a blood clot or a tumor, or if it gets kinked because of anatomy, it will reduce the outflow of blood. And it basically kind of becomes like a traffic jam. The blood is getting pumped into the head, but it's just not coming out so fast, so it tends to increase the pressure. So how do we evaluate someone we're suspicious for elevated intracranial pressure? And the first thing is history, and going over all these medical problems, because there, as I mentioned, several medical problems. There's a bunch more that I haven't talked about. Second is blood work. You want to make sure the patient's not anemic or have endocrine problems and those sort of things. And then next, and probably one of the more important ones, is imaging. Imaging in the form of MRI of the brain is helpful. First of all, you want to make sure there is no tumor or something that's blocking the sinuses and causing the elevated pressure. Now, on an MRI scan, you cannot see pressure, but you can see some factors that are associated with increased pressure, including things like something we call an empty sella syndrome, where the spinal fluid gets pushed into the area where the pituitary is, and it kind of squishes the pituitary gland, and we call that an empty sella. You can also see the lateral ventricles of the brain kind of shrink and get smaller. You can also see compression of the lateral lateral sinuses, and there's a number of other things, including Chiari malformation, that are associated with increased pressure. Then you want to do some sort of evaluation of the arteries and veins in the brain, and that's easily done at the same time as the MRI scan with an MRA, arteriogram, an MRV, venogram, so we can look at the arteries and the veins, and that can tell us if there's some kinking in the veins or if there's something called an arteriovenous malformation that can also cause increased pressure. Next, you want to get your eyes checked. As I mentioned, it's a minority of the patients that get this papilledema or a finding behind the eyes, but if it is happening, it can cause blindness. The pressure from behind the nerve can cause the damage to the back of the eye. Now, we all have a blind spot, and that blind spot is where the nerve comes in the back of the eye. And as the pressure goes up, it can actually cause further increase in the size of that blind spot, and it's often not noticed by the patient until it's very far advanced. So that's something that is picked up on exam by the eye doctor before the patient often notices it. Because this is affecting their ears, causing dizziness and balance problems, these patients, in my opinion, should get hearing tests to document where their hearing is, as well as vestibular testing. And then a sleep study for ruling out obstructive sleep apnea. As I mentioned, it's more common to see sleep apnea in patients who are obese, but there are certainly skinny people that have obstructive sleep apnea, and some of the worst cases I've seen have been in smaller people. And then lastly, some sort of assessment to see what is the pressure. Now, unfortunately, the only real accurate way of measuring intracranial pressure is doing something invasive like a spinal tap or a lumbar puncture. And it's unpleasant. It's a procedure that is invasive, but it will tell you what the pressure is. Now, it will only tell you what the pressure is at that particular moment. So that must be kept in mind too when the test is done. In my office, we have a non-invasive device. It's actually one of the few in the United States where we can get an idea of what the patient's pressure is non-invasively, actually through their ear. It's not as accurate as doing something invasive like a spinal tap, but it is non-invasive, and that's the major advantage. It's about 80% accurate. Well, once we have the diagnosis of someone having increased intracranial pressure, what can you do about it? The first thing is pretty obvious. Treat the underlying problem that's causing it. If it's from sleep apnea, treating the sleep apnea makes a ton of sense. If it's from an endocrine problem, treating that as well, and whatever medical problem the individual patient has. Beyond that, there are dietary measures that one should employ. Number one is avoidance of salt. Wherever salt goes, it drags in more fluid. More fluid, there's more pressure. So avoidance of salt. Avoidance of caffeine, which will dilate the blood vessels going to the brain and increasing the pressure that way. Similarly, any migraine triggers. Now, this is a little more specific to people that have migraines, but there are certain foods like red wines and cheeses that will cause a similar effect with dilation of the blood vessels and increased pressure in the head, and those should be avoided if those affect the patient. The last one that probably makes sense too is avoidance of hypoglycemia for the similar reasons. Now, there's medications to help lower the pressure. There's two major classifications of medications. The first is diuretics, which are just make you urinate more and gets rid of fluid from the whole body and hence lowers the pressure in the head. More directed to the intracranial pressure, however, are a class of medicines called carbonic anhydrase inhibitors. And the prototype for that is Diamox, also known as acetazolamide. This medication lowers the pressure by reducing the production of spinal fluid. And it's very effective. It's been used for this for many, many years. The medication's old. It's probably been out 70 plus years. If these medical treatments are inadequate, what can you do? There's still more you can do. Number one, you can just do repeated lumbar punctures and keep draining the pressure down. The problem with that is, as I mentioned, the lumbar puncture is an invasive procedure, and it generally only lowers the pressure for a short period of time. Most people, when they've gotten a lumbar puncture, the pressure is back up to where it was within anywhere from a day to 3 days later. However, there are some techniques to try and keep it lower longer. Next, there's interventional radiology techniques. If you're one of these folks that has a kinked vein draining blood from the brain, the radiologist can go in through one of your vessels and put a little stent in there to open it up, very similar to how they do stents for coronary artery disease. And that's been shown to be fairly effective in lowering the intracranial pressure. Lastly, if none of these are effective, or if you're not a candidate for the interventional radiology, the neurosurgeons can do something called a ventriculoperitoneal shunt. And that's where they put a tube into the ventricles inside the brain, and the tube runs underneath your skin all the way down to your abdomen and basically dumps the spinal fluid into your belly. And that way you can't get really high pressure because it just acts as a release valve. So as you can see, there's a host of different causes for increased intracranial pressure. It can cause a lot of different symptoms that can be confused with other things like migraines, but there are treatments for it. I haven't covered all the causes or all the perturbations on this. Probably one of the common things I see in practice is someone who has both elevated pressure as well as another inner ear disorder, such as third mobile window syndrome. In those patients, in my opinion, the first step is you need to get their intracranial pressure under control before considering any surgery for those folks. So that's it for elevated intracranial pressure. I hope you found this helpful, and we'll be back soon with more information. Thank you.